intervention perspective, does it have utility? That is, does it provide us, if not today, maybe tomorrow, a way of treating or preventing in the same way that the kind of work that Danny just presented does?
Could I go first for that one? Really hear me? Yeah. So, yeah, I think that's really, I mean, that's basically why I moved to Boys Town. When I was at NIH, I was doing the classic 20-person, 20-person study, you know, CD versus non-CD, high CU versus low CU. It was fun in the sense that we could identify group differences, but we'd never be able to translate that into anything clinically useful. Everything at Boys Town is oriented towards actually translating into something useful. So for me, what I think I'm trying to do with those neurocognitive systems, we've identified them, that's from the basic literature as well as we see the impairments in the patient population, they become the treatment target. It's not so much about whether the person, you know, because we know kids, you put one person in one environment, you put them in another environment, they can do very different profiles, but their underlying biology is still going to be the same. If we haven't addressed that, if they go back to the maladaptive environment again, they're in all sorts of trouble. So that's the first way I would say it. I mean, we still have to be able to do that at an individual level, but there are, you know, with all this machine learning stuff that's coming through right now, that holds up the promise, or at least the potential, for individualized assessments based around their brain level difficulties. Secondly, you've got the issue. I mean, when we look at the case with CD, we have cases with CD with, you know, the high-level empathic problems and the low-level fear problems. And the high-level fear problems, the exact opposite. Both of them are high risk for antisocial behavior. But one group really needs some sort of emotional regulation intervention. The other group needs to have something that's going to help them have an emotional response. We could say, well, maybe we just ask everybody whether they've got CU traits or not, and that, to a certain extent, will differentiate. But now that's from the imaging data and also quite a bit of actually autonomic data as well, that if an individual has suffered from serious levels of maltreatment, they'll present like they have CU traits, but the biology is that of the highly emotionally labile individual who needs to be addressed by reducing their emotional responsiveness, not increasing their emotional responsiveness. And each of those four systems have potential, at least theoretically have intervention. We know that that acute threat response, in the clinic, we've come up several times about trauma-focused interventions, but you know, any intervention based around anxiety should be reducing that threat sensitivity down. So if we're identifying a kid with high-level threat sensitivity, that's underpinning their aggression, then we should be able to see both whether it's pharmacological or a psychosocial intervention for reducing threat responsiveness, that should help. And what's more critical, we can then also see whether it has or has not addressed the problem by seeing whether the system's working at a healthy level or not. Response inhibition, there's a whole bunch. I mean, methylphenidate does work for some kids. The trouble is methylphenidate's given for any kid that even looks like they possibly might have just jumping around a tiny bit, they'll be put on methylphenidate, rather than targeting for those individuals who just have response inhibition type problems, as opposed to reward and sensitivity problems, which may or may not be also addressed by methylphenidate, but we don't even know whether the reward sensitivity problems are associated with a clear signal for methylphenidate. We do for response control, we don't for reward. So and the same with the reinforcement decision-making architectures. There will be interventions, you know, certainly some Boys Town program, but other interventions out there are focused around giving kids a better way of accessing the data they have available, the emotional response data they have available, to make good decisions. And again, we want to see whether that does lead to a more well-functioning system, and whether that increased well-functioning system is then also correlated with their symptom reduction. So I think yes. I mean, I really do. I mean, that's why I moved. It could be, as I said to somebody before, it could be my worst career decision ever to go from the safety of NIH to the non-safety of an intervention centre. But with the population they have there and the access to clinical resources and being able to ask trauma-related questions, which if I asked at NIH anybody about trauma, I would have been in front of the IRB faster than I could say, no, it wasn't me. So that's the whole reason for being. And I wouldn't do it if I didn't think that there was a hope.
That's all right, I'll be short. I think, Jane, that what you're asking is, well, all this brain imaging, neurobiology, all sounds very fancy and neat, but at the end of the day, where's the traction when the rubber hits the road? how is it going to lead to new interventions that's really going to give us something new that we don't have right now and that we wouldn't have come across unless we'd studied neurotransmitters or hormones or pieces of the brain. I think that's such a deep question because actually I'm not entirely convinced that we are really making a lot of great progress moving from basic science knowledge to new treatment programs. I'd like to think that we will. I can give you just a very crude example, sort of based on what I talked about this morning. So, basic science question, brain imaging, you find violent offenders have poor functioning in the prefrontal cortex. So that's the finding from the basic science. So that moves us to, okay, well how about if we electrically stimulate the prefrontal cortex? Will that do anything about that particular part of the brain? Will it do something in terms of reducing impulsive aggressive behavior? And as you saw, that's just very basic preliminary pilot data. That's almost about the best I can do in answering your question. Just going to my history, I got onto omega-3 because we had done some basic science research showing that poor nutrition is associated with later antisocial behavior, and that an early enrichment, which gave better nutrition alongside more physical exercise and the cognitive stimulation, reduced crime by 34% down the road. When I went to look back at the treatment program to see what was it about the nutrition that was really different between the experimental and the control group, the one thing that really came up was that the experimental kids, turned out, they got 2.5 portions of fish extra per week than the control group. When I left Mauritius, I was on a long flight, and at the bookstore I thought, let me buy a book to read. This is back in 2002. In that day, there were very, very few English books in the tiny bookstore at Mauritius Airport that I could possibly read. The bookshelf with English books was this long. One of the books was the omega-3 story. So put 2 and 2 together, and I thought, right, omega-3, biological, benign treatment, but can that make a difference? So that's why I've been doing omega-3 studies now. I'm trying to connect the dots here between something from basic science and how that moves us to some sort of biological-like intervention. But gosh, you know, I think you put us on the mark here, and I just wish we were making more progress than we have made in my lifetime at least, in terms of moving basic science to something practical that you all can use.
I'm not sure I remember the question anymore. I'm kidding. I totally appreciate the question. One of the things that I teach in both my grad and undergrad classes now is that, ironically, the neuroscience revolution, at least in psychology, is taking the psyche out of psychology. And that we need to understand emotional processes, to understand people. We don't understand people by understanding patterns of brain activation. Emotion always figures prominently in the presentations that I give, but also in the interventions that I've worked on. I also think if we expand sort of the scope of the discussion to all sorts of other adjustment problems that kids and adolescents and adults experience, one of the things that we've learned in the last 10 years in particular is that there are some common affective processes that seem to be disrupted in all different forms of human dysfunction, for lack of a better word. It's not the word I like, but it's the word that comes to mind, and that there's some commonalities across those that basic science has shed a lot of light on in terms of frontal cortex function. A lot of that has to do with how we experience emotion, not only internally, but in our social interactions, especially with families. So the work that I showed with adolescent girls and their moms, emotion is an enormous component of that. And how do we intervene with those really fiery emotional responses and experiences. That helps us identify targets. But I agree with Adrian that I'd like to see a lot more.
I just want to, I'm sorry, but I mean, we're right now in a situation like we roughly 8, 9, 10% of kids get given methylphenidate. And that's because we don't know which kids are going to benefit. And we're only going to know on the basis of the neurobiology. We clearly are not going to have behavioral markers for which, at least given people have looked at it time after time and not succeeded. We have a situation where, came up with, talks the number of antipsychotics that are being used with kids, adolescent kids. Kids coming into Boys Town, they're almost all of them, as they arrive, on at least one antipsychotic, some of them up to 5 different antipsychotics they've been given by pediatricians. All because nobody has any index about whether any of these medications are working. So they just put one, and when that doesn't work, they put another one, they don't take. And the only way we're going to be able to help people is if we can actually have metrics of their underlying problems and see whether they're addressed, like you do with any other form of medicine. You want to be in a situation where you see the person has got better with objective measures. And so, that's what I think is the big, that's either going to change it or we can't do it, in which case that's too depressing to contemplate. But I'm not going to contemplate it because I refuse to be depressed.
Any other questions?
Hello, my name is Franz Kurtzky. A little bit taller than that, sorry. I'm a philosophy student at the University of British Columbia.
We don't take questions from philosophy students.
Well, I really appreciated the philosophy bits that you put in there. As somebody who's taken courses in ethics, biomed ethics, and social and political philosophy, some of this sort of brain science angle is something I've not had exposure to. So I really appreciate that. I think it's very, very interesting. There's been some discussion of cognitive function today. And I was wondering if you could speak, if there's any research about male overrepresentation in violence in relation to the greater male variability on IQ. Because some of the reading I've done suggests that there is more representation among violent offenders on the lower end of the IQ spectrum. And if there is a greater variability for males on IQ, then there will be more people in that level of the spectrum. So I'm wondering if any of you could speak to whether there's any research in that area.
Well, I think you've given the answer, though, haven't you, that you've got more males at the low end of the IQ spectrum. Low IQ, one of the best replicated cognitive correlates of later crime and violence, presumably reflecting some degree of brain dysfunction. And so there you have it. That's why males are more violent.
I think it might be a good marker, assuming that's the case, that is all the case. It might be a good marker of the fact that the male brain may be at increased risk, the vulnerability that Adrian was mentioning, and potentially the vulnerability during pregnancy. There's been some literature suggests that the male brain may be more sensitive during that time. And if that is really the case, you could imagine that it's actually, for whatever reason, the male brain is more vulnerable, assuming it is, that you get the IQ problems and you get these other sorts of systemic problems that increase risk for violence in males.
I mean, it's extremely depressing because what little exposure I've had to that, the concepts around IQ is that it's not very flexible. I mean, there's not very much that you can do to help somebody in terms of raising their IQ, right?
No, that's not.
Well, yes and no. I mean, again, context. IQ, again, arguably one of the most genetically informed variables we have, is that fair to say? But in the context of poverty, 60% of variability attributed to the environment, according to Eric Turkheimer on the subject. So there is, context does affect even IQ. and aggression, of course, the same way.
Could you talk a little bit more about that place?
Yeah, so a lot of the original IQ studies were done on primarily fairly stable, well-resourced families over time, and very few had been done heritability studies where there had been large variability, much like adoption studies in families who were in need financially. And when that was done, that correlation from parent to child attenuates substantially because of greater variability in the environment.
Interesting. Well, thank you for making an exception and taking a question from a philosophy student. I appreciate it.
Tom Deschamps is a philosophy major. My son is a philosophy major, so I had to.
Fantastic. Thank you.
Hi, I'm Tekla Johnson from Santa Fe. I work with young children here and families. And I was just wondering about meditation. Like, I've seen a lot of brain scans and information about how meditation actually changes the brain and what's going on. And I'm just wondering how that's been used, or how, if that's been studied with boys or children having these challenges that you've been talking about this morning.
I'll go quickly. You're dead right. There's quite a bit of experimental work showing that mindfulness training enhances frontal functioning, upregulates amygdala functioning, partly, I think, because mindfulness focuses your mind on how you are feeling at the moment in the time. So when we talk about poor frontal functioning and amygdala impairments, it's maybe one of the first sort of benign treatments that maybe can enhance the brain to reduce aggressive behavior. I've looked in the literature on it, and there's really very few randomized controlled trials on this. There are studies. I mean, one study is large enough to have included 1,300 prisoners into mindfulness, claiming that mindfulness training reduces hostility and aggression. Not a randomized controlled trial, though. So at least my mind is open to mindfulness as a way of changing the brain to change aggressive, violent behavior.
There are, Adrian and Ted and I both sit, at least sometimes, on a NIH panel, it's a prevention panel, and there is more interest in that, and it comes two ways. Some are training kids, middle schoolers, for instance, but others are training parents to also be more mindful. Some people looked at our family checkup and said, you're basically teaching parents mindfulness, because you're getting them to slow down, to identify what you really want in the big picture, and to get them to actually think before they act in some ways, which gets at meditation and mindfulness, those concepts.
Sometimes I think I have a hammer, so everything looks like a nail to me. I'm a psychiatrist, so everything looks like depression to me. And for instance, in Theodore's talk, he gave a brilliant talk on the multidimensionality of the factors involved in this elongation of the history of an individual. But in my own history of individuals, when I'm evaluating them, I have a question that I start with. I asked them, if your mother was here, and I asked her, what were you like as a baby in her arms? And then if they begin to tell me that, well, I didn't sleep well, I didn't eat well, and whatnot. Then I go on to ask them about nightmares, I go on to ask them about school refusal, things like that. But my point is this: I feel, and by the way, talking about longitudinal experience, I've been at this for 50 years. I tell people, they come into me in my office, I say, I was sitting, you weren't born when I was doing this, all right? So I've been watching this over generation after generation after generation. And for instance, I feel that if there are affective studies connected to each one of your disciplines, for instance, in regard to these interventions, in regard to the families, I would suggest that the basic problem is whatever circumstances they're under lead to depression. And it's the depressive experience that you're mediating when you get interventions. With the ADHD kids, I'll get a kid that's jumping off the couch, or I never put them in a chair that swivels. I only put them in I ask my ADD kids that sit on the couch because they can't turn it. But then I give them antidepressants. So again, I may only have a hammer, but I feel that the affective component of all of these, whether you discover defects, but then look for affect, or you look for affect in criminality, and longitudinal affect from the time of childhood. Again, depression, depression, depression. So I'd like to hear some comments on that, and how you might factor more of an actual management of the depressive experience into each one of the aspects of this that you've been working on.
I'll say a couple. I mean, one thing that, so one of the things that both Ted and I talked about was that reduced striatal response to reward. And that is also a feature seen in a lot of kids with depression. So it's quite possible that what happens when you're given the SSRI, which we don't really know to what extent that actually does pick up the striatal response to reward, because I haven't seen any clear data on that, and I haven't seen anything like that now. But in theory, we would like to believe, I would like to believe, that a successfully treated patient with depression brings that striatal reward back into a healthy level. And assuming that's the case, and given that we see that in a lot of our cases with CD, and Tony also reported the same with the sort of impulsive to aggressive kids, you can imagine that perhaps that's, many of the kids, do benefit. Fact though is, I would caution, because that is one of our risk factors, clearly one of your risk factors as well, but it's not something that's shown by all of these kids. It's just one of a potential neurobiological risk factor. And so for a whole bunch of other kids, the strong suggestion would be it might not be so fantastically helpful. But, obviously it's an empirical question. It is even possible that SSRIs have a much broader impact. They might be hitting all four of these systems that we just don't know yet. I mean, again, this is partly, and back to Jay's point again, without knowing what these drugs are doing to the brain, what systems they're bringing back online and taking to a healthy level, it's very difficult for us to really know how to best manage these kids.
To springboard on that point, and a point you made earlier, James, we know, of course, that not all depressions are the same, and that we have these anhedonic depressions that are rooted in low striatal responding, and yet the formulary is to give SSRIs first. And one might guess that an NDRA might be more effective with that type of depression, but we don't. We base those decisions on behavior and not brain function, and so I agree on the earlier point and on this one.
A couple of points. For about 10 years, I worked with a woman named Marika Kovacs who studied childhood onset depression and followed her cohort all the way until they had kids, and that's when we collaborated on their offspring. And of course, she thought everybody was depressed, I was like, well, some of our kids are, but in fact, if you look at her data, the kids that continue to be depressed as adults, some of whom become bipolar, are those that are comorbid for conduct disorder, not vice versa, over time. In the MTA study that Ted talked about, 10% of the ADHD kids were qualified as depressed, probably more in the girls, I suspect, but which is interesting. In our own data, I would say 5 different cohorts, followed from around infancy or 2 all the way to 15 or beyond. Again, recruited based on screening for conduct problems, we tend not to find more than 15 or 20% in that range over time. What is interesting, and I think what is valid about your point, is that we see a lot of kids having mood regulation problems, and we see collateral effects of our intervention on depression if we change parenting, their regulated behavior, or mom's depression. So there is something there in what you're saying, but I just don't think the proportions. It is a pathway, it is common, but not the modal topology that we see among our kids who are recruited based on conduct problems rather than depression or something like that.
It won't be news to you guys, but a lot of people now are questioning all these separable and seemingly distinctive psychopathological categories, diagnosis, disorders. be depression, bipolar, schizophrenia, autism, conduct disorder. And, you know, with the evidence suggesting there's an underlying, you know, liability that goes by the name of the big P, because all these phenotypes load on the same factor. Could you guys reflect on how that emergent, seemingly new understanding relates to so much of your discourse today, which is really picking out this particular disorder and that particular diagnosis?
Oh, sorry, no.
I just would say very quickly that that's exactly what I hope to not to do in my talk. So, and then I'll pass it on.
Yeah, I mean, that was the whole point of having those 4 different neurocognitive systems related to symptom sets. The fact is that they are 4 independent neurocognitive systems that have specific types of symptom sequelae if they are dysfunctional. Those aren't symptom sets those aren't systems that are tied into individual diagnosis. They are more common in some diagnoses than others, but they are not specific to those diagnoses. No, I don't really, I mean, I cover the diagnosis because if I want to get published in the Psychiatry Journal, I have to. But the fact is that, no, I think we need to be in a situation where we're getting rid of those diagnoses in favor of specific systems, and again, whether those systems are addressed or not. With respect to your secondary point about this one unitary factor, yeah, I think there is a one unitary factor. When I look at that literature, it looks like IQ to me. And, you know, just like Adrian was saying, a big risk factor is a big risk factor for just about everything. The neural circuitry they typically identify relating to that one underlying risk factor, it's the same as we see in IQ, or very, very overlapping. So I think IQ is a massive risk factor for all psychopathology, or something, you know, the general functional integrity of these core systems that are involved in processing information rapidly. And that if that circuitry is not working so well, you're at risk for, you know, doing disruptive behavior, for more likely being depressed. Because you can't sort of work your way out of your depression by doing cognitive reappraisal yourself, because you don't have the intellectual equipment for it. You can't regulate your behavior generally because you don't have the intellectual. So I think it is, but I don't think it's actually going to be, we get rid of that, we get rid of all these diagnoses, we get rid of everything. Because it's very, you know, you've worked with patients. I mean, I think you have a patient with social anxiety disorder. They do not have the same problem as a patient with conduct disorder. And in their brains, they do not have the same problem as a patient with conduct disorder. There may be a case who does have the two is comorbid. There is comorbidity of SAD and conduct disorder, but that kid is going to be that reactive form of CD, not the CU form of CD, or the low empathy type of form of CD. So I really do think there are specific mechanisms to symptom sets. I think the data is really quite clear that that is the case. There is this underlying, you know, this basic risk factor as well, but, you know, I think that's primarily IQ, maybe a few other bits and bobs.
I always like to make the point that, at a very slightly broader perspective, that there are people in this room, probably quite a few, who experience debilitating anxiety, but you're here and you make it to work every day. There are people in this room who experience pretty severe impulsivity, but you're here, you make it to work every day. And what enables people to do that is this strong top-down control over those emotional responses. And I think that's consistent with what James just said. And so I think of it as IQ, as self-regulation, as emotion regulation, as broader frontal function, and that being sort of the substrate, if you will, of P or whatever you want to call it.
Yeah, we're reinforced by our funders, by our journals, by everyone to go into these silos, but I don't think any of us think that way in terms of conceptualizing.
And I just add in, I concur with my colleagues really, Jay. I think with violence and trickle down to aggression, of course aggression occurs in many different diagnoses. I think where the challenge is working out what treatments are going to work for what form of aggression in what clinical group, because I think the effective treatment for aggression in conduct disorder may be quite a different treatment for treatment of aggression in autistic kids. I think with autism, to treat aggression, first thing you go to are atypical antipsychotics, and that may not be the most effective route for conduct disorder. Jay?
You know, in the most recent issue, I think, in the Journal of Psychiatry and Psychology, the editorial actually raised just the opposite suggestion on the basis of communication, which is the order
I think, no, it's great. I think that you're perfectly right. I mean, the fact is, although I'm, obviously I think the IQ issue, big P is an IQ or a regulatory issue or something, or the lateral frontal parietal cortex doing attention type stuff. All of those sorts of things are big. I mean, it's a lateral frontal that tends to come up as the big P area in all of at least the papers I've been reading. So, whatever it could be, you could address that, and you can have a pretty good effect. I mean, to be honest, I think that's what most psychosocial interventions do, is they go after big P. Because you see these non-specific effects, and they're not small. I mean, the ones that work, just like we've just heard just before, I think they're big P effect studies, because they're not really targeted necessarily for CD or depression or ADHD. They're targeted to help kids and help families. So I think they're big P solutions. But do I think that they're going to be the end of CD, the end of psychosis, the end of depression? I don't. Even though I'm based within the psychosocial model of Boys Town, I think it's an incredibly effective psychosocial model. I'm a strong supporter of psychosocial models. But I don't think if we just have a broad picture one, we're not going to be able to, help people the best that we can possibly do. The case with, just like you said, about the person that comes into work, massive debilitating social anxiety, but works their way through because they have dealt with their big P issue, or didn't have a big P issue, and fought their way into work. They're having a really sucky existence. We would want to help them too. So I'm definitely not suggesting we shouldn't do it. I do think that we actually already are doing it. But I think we need to be in a situation where we can say, look, this person has this condition, and this condition is based around the systems in the brain that aren't working so well. And now, look, we've done X, and they are better. Just like I want my blood pressure pills to say, my blood pressure's in the healthy range, I won't have a heart attack today. That's what I want. I want that sort of, or at least my risk factor for a heart attack is substantially reduced. I want to have an objective measure that says, I'm back within a healthy, or at least as healthy as I possibly can be range.
Okay, I would say in a way, Jay has already asked the so what question in terms of what does the basic research mean for interventions. But my question is more, so what about the contexts that are highly resource deprived and high in violence? I think this was alluded to by one of the women on that side working in rural New Mexican contexts where there are so many issues in terms of resources, the ability to create interventions. In the work that I'm doing in high violence context in South Africa, that's certainly the case. Mental health services for Black communities are non-existent, and it's even non-normative that a Black South African person would consider that they have depression or would do something about it. Yet, probably if you were to measure trauma and depressive symptoms, they would be in everyone. So really the question is about both where is the primary research going in terms of working in high violence context, highly resource deprived high violence context, and what are the prospects for interventions that would work, that don't require massive costs, massive infrastructure, massive implementation, program fidelity to actually try to treat not just the individuals who would be showing this classical symptomology, but the communities that I would argue have much more going on in terms of a toxic mixture of violent repertoires than the specific individuals within them. And that's all set against, I would say also, these growing questions of inequality. Clearly we're seeing dynamics happening not just in the country, but across the globe with growing inequality, further marginalization of already marginalized communities, and the likelihood that these are creating greater tensions, less pathways towards, we think of the typical education pathway out of poverty, but that may not be normative for communities like these any longer.
We've got limited resources, and the big question is, do you target the groups in most need, the groups that you've been talking about, the underserved in the community, and put all our eggs into that basket to really do as best as we can for the people who really need the help? Or is that just plain old stigmatizing yet again? And should we instead take a more public health approach and try and For example, enhanced impulse control across the board for all kids in society. And so I grapple with that issue and problem. I mean, as a utilitarian, I think the best investment society can make in its future is investing in the early years of the child. We're not doing it. I think there's reticence about it, and I think there's some ethics surrounding that. I don't know what my colleagues think.
Yeah, I'm always torn on this. It's a great area. I recall Salvador Minuchin, who began his work in the slums of Philadelphia, gave up on low-income families, treating them as structural family therapy because he said it was like putting Band-Aids on gunshot wounds, which turned out to be all too true down the road. On the other hand, I look at our research, and we're having our greatest impact with the most deprived families that we see. At the same time, I remember getting a question at one of these talks recently, and I said, well, if poverty were eradicated, would you be doing your intervention? And I said, probably not. Probably wouldn't. So we're constantly, alluded to, moving upstream against, and again, depending on the country you're in, or maybe the time we're in the United States, it's never seems easy. And so what do? Adrian's point is very well taken about where do you put limited resources and where's your best thing. So I go back and forth. Right now, I'm in the camp of let's try to help those in the highest need, but that's nothing compared to other countries. I realize even though America seems I do work in Norway and Sweden, and things are a little bit different there. So I see that things might be possible, that countries can devote resources to early childhood and other things. So I do see that light sometimes and have hope for America on occasion.
I compartmentalize in maybe an unhealthy way. So I go to my day job and I do the best I can. And we try to take interventions to people who are in highest need, knowing that that's 1 out of every 99 kids, let's say. And I go home and I watch the news and I see income inequality grow, and I see that that's drawn almost completely along racial lines in our country. And I don't want to be part of the country that I live in when I see those trends worsening, and I see every dynamic pushing them in the wrong direction. We have institutes of public policy, every major research university who, and it's their job to try to deal with these issues, and to what level of success. I don't know that I can bring anything. I wish I could.
We have one last question.
Yeah, my question is kind of around community and intervention. You were talking about like intervening at certain times in development, and I kept thinking about the ability to do so. And so Joanne Schleidel wrote in her book, she referenced a study that said that a kid who has 2 or more unpaid people, consistent unpaid people in their life, will do much better. And then Sebastian Younger referenced another study about war veterans and PTSD and how those symptoms tend to show up when they're not in their military community. They come home and they get stateside and they feel these things. And so in my mind, as I'm studying these things, I kind of differentiated between superficial communities that we tend to create here, right? Sports teams, even treatment teams, right? I mean, we're a part of their community, but their survivability, our survivability, there's no interdependence, and there's no necessity for things like forgiveness or anything like that. So what I'm wondering is if you guys have seen any studies, or if they've been able to isolate the variable of maybe what I would call an authentic community versus superficial community, and what impact that has on what we talk about.
There's a pretty good body on neighborhood belongingness, cohesion, and controlling for the same number of other adversities at poverty, so at a more global level, how these factors can be protective within a community despite the poverty going on. Within this whole Pittsburgh study I mentioned earlier, there's a group called Bright Spotting, and they're trying to find out if there's a community in Pittsburgh called Homestead. And Homestead, despite having very high poverty rates, has not had one case of infant mortality in the past 8 years. Where in other nearby communities, I mean like 2 miles away, there have been 40 cases during that same time. How do they do it, right? And so instead of looking at, again, the vulnerability aspect, they're trying to isolate factors that promote, positivity, going back to your question, in the context of poverty. Like, how does this community pull it together? So, Gene Brooks-Gahn and other folks have focused on factors like, and Sampson and University of Chicago, focused on factors like cohesion and belongingness despite that. In Pittsburgh, we have what are called family support centers. They were identified by our director of Department of Human Services in the mid-90s, where this whole shooting rampage I talked about earlier, and it wasn't safe for parents to literally cross the street with young children. And they located these centers, 28 of them, in low-income areas throughout the city to try to foster that, to try to build that community. I think it worked in the 90s, and now parents are working 2 jobs and they're underutilized, so we need a new model. So to answer your question, I think there are efforts to make that, but it's really trying, especially in this context where a lot of parents are working 2 or even 3 jobs. When do I have time to have that community? I'm really stressed out. I mean, that's what Pittsburgh's like, I can tell you these days. I don't know about what's going on here.
Okay, I think that's it. We have a break and then workshops. Thank you.